Hi class, we're going to be talking about major depressive disorder in today's lecture and the other depressive disorders and associated symptoms, as well as start our discussion about suicide. And just to get started, depression is a very common condition, and it's also an emotion that you hear a lot about. And the truth is we probably mean a lot of different things when we hear the term depression. And because of that, it's important that we clarify the difference between depression as merely an emotional state and depression is a condition. Depression is often referred to as the common cold of mental illness, meaning that we'll all catch it from time to time. And most of us know what the feeling of hopelessness or sadness feels like, as it may briefly come in and out of our lives, depending on our circumstances or things that may be going on. But when it stays around for a bit, we might describe ourselves as feeling depressed, but the clinical forms of depression that we're going to be discussing, they have specific diagnostic criteria that may distinguish it as a disorder that requires treatment. In other words, it's different from just a transient mood state that sometimes we refer to when we talk about feeling depressed or having some depressed feelings or thoughts. So what does depression feel like? It's important for you to know this information, to get an idea of this. I've included a YouTube link for you to listen to get some more input on this. I want you to listen to firsthand what some of those descriptors might be. You'll hear many people use terms such as hopeless, it doesn't matter anymore, who cares, why try? Nothing seems to sound good to people that have depression a lot of times. You may hear things like, I feel tired all the time. I don't feel rested when I wake up. My body hurts. I don't feel like I can get out of bed in the morning. This is why depression is sometimes considered a total body disorder. It is like the color has gone out of the world. Everything is black and white. Things that used to feel good don't anymore. Food that used to taste good doesn't have the same taste anymore. Activities that used to be enjoyable are loathsome. People that used to be fun to be around now feels like an effort. Music that used to be soothing now sounds like screeching. In one way of thought, it's a great distortion of perspective. It distorts your image of yourself, your world, and everyone in it. And I may have mentioned this to you last week, but it is, in a way, looking at a distorted image of yourself and the world and believing what you perceive more than what is actually there. This type of presentation and line of thought may alert you to the presence of a diagnostic depressive disorder. So our objectives for this lecture are to answer some questions. Number one, what is depression? How would we define it? Number two, why is recognizing depression in our population so important? Three, what substantiates the diagnosis of major depressive disorder and some of the subtypes in the diagnostic criteria? Number four, what are the clinical subtypes of depression? Five, what are treatments? And we will do an introduction to that today and get more into that in our next lecture. And then finally, what is the biggest danger of depression? So here's the question. What is depression? It's a mood disorder that's widespread and debilitating, with one of the highest rates of disability worldwide. It is believed that 20% of all people will at one point have some experience with depression in their lifetime. Secondly, major depressive disorder is the most common form of depression, and it can happen at any stage of life. Most often starts in young adulthood, and it is most common in women. Actually, it's 2 to 1 between women to men. Major depressive disorder is the primary diagnosis with some subtypes that have very similar diagnostic criteria. All of the depressive disorders have a cluster of symptoms that impact thought, feeling, and function of an individual. So there's some key concepts that are associated with major depressive disorder. And you'll hear some of these when you hear people talking about the disorder. When you start talking about a persistent depression, you're talking about from 2 weeks to about 6 months. If you hear the term chronic, that means that someone's probably been struggling with major depressive disorder for longer than 2 years. In this disorder, recurrent episodes are common. It's mostly described as an episodic disorder, meaning that it'll happen at different stages throughout your life. And to get the diagnosis, the symptoms have to cause some type of significant distress or impaired function. That means that you're not able to work effectively, you're not able to be in relationships effectively, you're not able to go to school or attend or complete your usual functions of life. And these features cannot be attributed to something that's happened in your body, like a physiological effect, or it cannot be in the absence of a manic or hypomanic episode. The cause of depression isn't always so easy to concretely describe. It's considered to be multifactorial. As we've discussed earlier, questions about the etiology of depression often come down to a couple of questions. Are you born depressed, or were you made that way? And as we know, and have spoken about before, it's probably a little bit of both. There are some biological factors. Some of these are listed here through some of the studies that have been done. There's genetic factors that have been proven. There's biochemical, because we understand that the serotonin, norepinephrine dysregulation associated with stressful events creates some dysregulation within the brain. Alterations in hormonal regulation and stress affect our hormone level. The inflammatory process has been proven to influence, as well as the diathesis stress model, which is basically the nature versus nurture. So there are lots of biological factors that influence it, as well as the psychological factors. Beck's cognitive triad, and Beck is the one who came up with the whole cognitive behavioral therapy, which we'll talk about later, but was this idea that these negative thoughts about oneself, world, and future had a great impact in one's perspective and experience with depression. There's also some understanding that because of early experiences in life, there's a learned helplessness that begins to develop, meaning that one learns to not expect anything else but powerlessness and failure in life, and they begin to expect it. And so it starts a cycle of behaviors and thoughts and actions that contribute to further depression. But as I said before, it's best understood as the causation of depression is best understood as being multifaceted. Our second objective is, why is recognizing depressive disorders important? And it's important because depression is a big deal. It's a big deal because of the prevalence in today's society. It means that it is something that you want to consider frequently as a differential diagnosis. It's got to be high on your list of rule outs. It's actually been said that if we could eliminate depression, we could eliminate death and disability by 10% worldwide. Now we know that we can't do that. And since we can't yet eliminate it, at least there are multiple treatment options available for depressive disorders. So there's multiple treatment options. So being able to recognize it means that we have some more options to offer people help when they need it. If you're going to have a mental issue, depression is one of the ones that at least has a lot of options in regard to treatment. Another reason why recognizing it is so important is that there's a high mortality rate associated with depression due to the risk of suicide and how it affects health outcomes for individuals in general. Depression worsens outcomes for already existing health conditions, which is really important to know when we're involved with trying to help people increase and improve their health outcomes. There are several disorders that have a high comorbidity with some of the depressive disorders. Anxiety disorders is one of the most significant ones, and sometimes it's difficult to tease out the two because a lot of times you may have a depressive disorder that has anxiety as a symptom, or an anxiety disorder that has some depression as a symptom. And because these two conditions often overlap, it can be a little tricky to detangle which one is primary. As far as substance use disorders, it's highly comorbid with depressive disorders because a lot of times people with depression will use alcohol or substances as a means to cope with their depression. Eating disorders, personality disorders, and psychotic disorders you also see comorbid with depressive disorders. So what is the diagnostic criteria for depressive disorders? Major depressive disorder is the standard for the diagnostic criteria since most of the other depressive disorders share many of the same symptoms. At least one of the symptoms have to be a depressed mood or anhedonia in order to have the diagnosis of major depressive disorder. So if you are wondering if someone has depression, and if they do not have either of those symptoms, you can rule it out. The criteria shown on this slide for the 8 additional symptoms plus the depressed mood is often used the acronym SIGI-CAPS to help remember them. And it includes some type of impaired sleep, which often means like an early morning awakenings or difficulty going to sleep at night. Or it may even mean waking up early and not feeling like you've been rested. It has a loss of interest or anhedonia, like I mentioned before. It makes depression a non-reactive state, and what that means is there's just not much of a reaction to anything. You might see someone who doesn't seem to get too upset about something, who doesn't get too sad about something. It's just a real blunt, kind of flat expression. Another one of the symptoms is a sense of guilt, worthless, or rumination, which means your thoughts kind of keep chewing over regrets a good bit. Energy is another one. That means a decrease in energy. This even looks like sometimes getting out of bed is just too much. Concentration difficulties are another category, which can cause impairments in work, school, and relationships. Appetite changes. There's a decrease in your appetite. This is when you hear people talk about like they just don't have a desire for food anymore, nothing tastes good, or maybe they keep trying to eat more food to feel better, to get some kind of sense of pleasure. Psychomotor retardation means that it's an objectively observed slow movement, slow motor. You can also see maybe even some psychomotor agitation sometimes where you see someone just feel like they can't get comfortable. They sit there not comfortable. If they lay down, they're not comfortable, and there's kind of this constant restless moving. Can also be a feature. And then finally, the most dangerous symptom or category of this is suicidal thoughts. To meet the criteria for major depressive disorder, you must have at least 5 of these 9 diagnostic symptoms over a period of 2 weeks for most of the day. There are a couple of specifiers to this diagnosis, meaning that a major depressive disorder that has some additional features to it. A couple of those specifiers, one would be major depressive disorder with psychotic features. And that is when there is the presence of auditory hallucinations or delusions that accompany the other depressive features. Another specifier is one that we're probably more familiar with, and it's major depressive disorder with postpartum onset, or what we often hear described as postpartum depression. And it is when a major depressive episode starts within 4 weeks of childbirth. This disorder can also include delusions that the mother have about the child, and it may put the newborn baby at risk. So other depressive disorders, which is our 4th objective, describe some of the other categories of depression, I guess you could describe. And even though they have similar criteria, they do represent their own uniqueness, which determines the most effective treatment for them. And those are substance-induced, associated with medical condition, seasonal affective disorder, premenstrual dysphoric disorder, and persistent depressive disorder. So substance-induced depressive disorder is depressive symptoms that are only associated with the use or with the withdrawal from a medication, a drug, or an alcohol. So in other words, the symptoms are only there based on the substance itself. Depressive disorder associated with another medical condition. It can be caused by kidney failure, Parkinson's disease, Alzheimer's disease, cardiovascular and cerebrovascular events or disease, but basically the depressive symptoms are there based on the medical condition itself. Seasonal affective disorder is a disorder that has a symptomology of major depressive disorder, but the occurrence of these symptoms is associated with seasons, and mostly during the winter when there's less daylight. And because of this, light therapy is considered the first-line treatment for this disorder. Premenstrual dysphoric disorder, or PMDD, has the symptomology of major depressive disorder, but it's linked to the luteal phase of the menstrual cycle. You'll also see some symptomology with this disorder with things such as mood swings. There's more irritability and feeling overwhelmed, and the difficulty concentrating. And significant with this disorder is the symptoms decrease significantly or disappear once menstruation is started. The last disorder we'll talk about is persistent depressive disorder. It was previously referred to as dysthymia, but it is a milder form of depression. And I used to refer to it as like a low-grade depression. and it usually has an early onset. In order to get this diagnosis, you must have had the symptoms for at least 2 years. The criteria for children is having it for just 1 year. And it requires that you have only 2 of the depressive diagnostic criteria in addition to the required depressed mood criteria for you to have the diagnosis. And you see a little bit more of the appetite, the insomnia, poor self-esteem, and hopeless thinking associated with this particular disorder. Okay, so let's take a minute to think about a question. What is true about major depressive disorder? A, it costs U.S. billions of dollars each year. B, it is a disorder that primarily affects the young. C, it is a common and relatively harmless condition. D, anhedonia is a diagnostic symptom for the disorder. And E, more women are affected. What do you think? So the correct answer is A. It does cost U.S. billions of dollars each year. Like we talked about before, it is one of the main causes of disability in the United States. B, that is not true because it affects everyone across the generation, even though sometimes it may start more in the young. C, it is a common disorder, but it is not a harmless condition. D, anhedonia is a diagnostic symptom for the disorder, and E, more women are affected. So when we're thinking about nursing concepts for depression, the most critical one we want to conceptualize is safety because of the possibility of suicidal thoughts. Additionally, coping is a critical concept due to the manner in which an individual is dealing with the symptoms. So before we get to the actual treatment, let's talk a few minutes about assessment. And as we've mentioned before, one of the first things that you want to assess is yourself. And what do you think about people that have problems with depression? Or what do you feel about some of the symptomology that's associated with it? When you consider these things, it helps you to hear more clearly what a patient may be sharing with you, and it gives you the ability to listen more freely without bringing to the table any judgments about it. Some of the assessment findings you might expect with someone who has depression, you would expect to see an individual talks a lot about not enjoying things anymore, or may express feelings of sadness, low energy, or anxiety. You may observe slow or agitated movement, or an individual may talk about the vegetative signs of depression, such as changes in sleep or appetite or bowel habits or even body aches. Some people with depression will be a challenge because you won't be able to tell from their appearance. But for many, you may see a blunted affect, maybe poor ADLs, someone who doesn't care about their appearance. One of the key terms in psychiatry, which you refer to affect, is a powerful assessment tool that you'll get used to seeing when you go into the clinical area. And basically, it's the expression on a person's face, how they present. And it is a key assessment area to begin to understand a little bit more about what may be going on with the patient. So as I mentioned before, there's several types of treatment that are indicated for major depressive and related disorders. I'm going to preview the treatments today, and then I'm going to discuss it more fully in our next lecture, especially about psychopharmacology and psychotherapy. But best practice indicates that treatment for depression involves therapy and medications or a combination, with the combination actually better than either one alone. So what that means is depression responds best with a combination of psychopharmacology with psychotherapy. There are other treatments that can also be used, and we're going to be discussing those for a few minutes as well. And they're generally reserved for those individuals who have what we call treatment-resistant depression, meaning that maybe they've had several trials on different medications with psychotherapy that just didn't seem to be effective. Or it could be that the patient cannot tolerate medications, and for some reason the medications would not be appropriate for that patient. But despite that, whatever treatment that an individual may get, the average length of depressive disorder can be greatly reduced when it is treated. And so that's why we were talking about before, that if you do have major depressive disorder, it is hopeful because there are treatments for it. A helpful model just for conceptualized treatment for depression is the biopsychosocial spiritual model. And what this demonstrates is the actual spectrum of treatment. Since depression impacts the body, the mind, relationships, and the spirit of a person, the most holistic approach is addressing all of these domains. Most formal medical treatments address the body through the medication, and biological treatments, they may address the mind through therapy and skills-based counseling, and then the social through therapy and support groups. Most of the time, the spiritual area is left up to the patient to find and discover that for themselves. But when we start talking about the medical or the biological treatments for depression, the primary ones that we're referring to are the medications that are used, the antidepressants. And these medications have continued to develop with improvements over the years. And there's about 4 primary categories of antidepressants, with another catch-all category to cover the atypical ones. The antidepressants that you hear the most about now are the SSRIs, or the selective serotonin reuptake inhibitors. And they're the category of antidepressant that you will see most often in practice. And this is due to their favorable side effect profile and their effectiveness. One quick caveat I wanted to add about treatment is the use of St. John's wort. And St. John's wort is an alternative treatment that sometimes people use to help treat the symptoms of depression. And it's a plant derivative. It is not regulated by the FDA, but you will see it in use a great deal. And it is vital that you know when a patient is taking it, because it can sometimes interact with other medications. Psychotherapy is another first-line treatment for depression. The most studied evidence-based practice therapy for depression is something referred to as cognitive behavioral therapy. And it has shown tremendous effectiveness in treating the distortions of perception that occur with depression. Other forms of therapy that you'll hear about include interpersonal therapy, which focuses on relationships, group therapy, which focuses on the relationships and dynamics of a group setting, behavioral therapy, which is one of the older therapies, which primarily targets behavior or doing different. Other types of therapy including DBT or dialectical behavior therapy, ACT or acceptance commitment therapy are branches of CBT and have their place in treating depressive symptoms. I'll discuss more fully the therapeutic treatments in our next lecture. Though not as common, there are other treatments that are used when medication, therapy, or the combination does not work effectively, or if an individual cannot take medication for some reason. One of the first ones that I'll mention is something called vagus nerve stimulation, and it involves the placement of an implanted device that actually stimulates the vagus nerve to treat the symptoms of depression, and they have had some effectiveness with this treatment. The second one is deep brain stimulation. A little bit rarer, but it is the placement of a neurostimulator that is similar to like a pacemaker, but it's for the brain. And it sends electrical impulses through implanted electrodes to target certain areas of the brain. You've heard about this treatment probably more primarily with movement disorders like Parkinson's, but they are finding some use of it in treatment-resistant patients with depression. ECT or electroconvulsive therapy, it's a treatment that was earlier referred to as shock therapy. It is an amazingly effective therapy. And what it does is it initiates a petit mal seizure, electrically induces it. I'm not sure how it works, but it is incredibly effective. They begin to use it, they've used it for many years, but obviously it's become way more humane now, where they used to induce grand mal seizures, and you would have problems with fractures or really bad problems with patients when they would induce these, but now they do it under general anesthesia. It's petit mal seizure, and it really does have strong effectiveness for people with depression. The last one I'll mention is something called transcranial magnetic stimulation, which is a newer treatment, and it involves using magnetic pulsations to stimulate focal areas in the cerebral cortex. So for our last objective, the question was, what was the greatest risk associated with depressive disorders? And the greatest risk is suicide. And we're going to discuss in our next lecture about warning signs and risk factors associated with suicide, and even how to conduct an assessment for it. So this concludes our lecture on depression and depressive disorders, and I hope that it's been helpful. We're going to continue this discussion with another lecture on suicide, its risks, warnings, and how to do an assessment.